Malaria is a very common infection and it follows the introduction of protozoan malaria parasites into the bloodstream by the bite of an infected female Anopheles mosquito. It is a major cause of significant morbidity and mortality, especially among vulnerable individuals such as children under 5 years of age, pregnant women, sometimes with adverse fetal and maternal outcomes, with patients with sickle cell disease, and visiting non-residents and expatriates. As based on the clinical severity, cases of malaria are categorized as either uncomplicated or complicated or severe. So, diagnosis of malaria can be suspected based on the patient's symptoms and the physical findings at examination. However, for a definitive diagnosis to be made, laboratory tests, blood film, or rapid diagnostic tests must demonstrate the malaria parasites or their components, since the clinical presentation of the condition can be similar to other common diseases such as typhoid fever, urinary tract infection, septicemia, pneumonia, and meningitis in both adults and children. Also, measles, otitis media, tonsillitis in children. Diagnosis is progressively being shifted from clinical to laboratory confirmation as the basis for treatment. Rapid diagnostic tests may be used to confirm a diagnosis if microscopy, as blood film is not available. Preventive measures in the community mainly target elimination of the insect vector or prevention of mosquito bites, while additional chemoprophylaxis is required for vulnerable individuals. The development of resistance of malaria parasites to antimalarial medications is a matter of major public health concern. This phenomenon is largely the result of overdiagnosis and wrong diagnosis of malaria by healthcare practitioners and patients alike, with its attendant over treatment and sometimes partial or incomplete treatment, leading to overexposure of the parasites to the antimalarial drug as drug pressure. Also, artemisinin combination therapy rather than monotherapy with artemisinin derivatives is currently recommended for the treatment of uncomplicated malaria to prevent the development of drug resistance. It is therefore necessary to obtain laboratory confirmation of a diagnosis of malaria before starting treatment. Exceptions to this principle are children under 5 years and cases of suspected severe malaria, where laboratory confirmation is not immediately possible. In such circumstances, a complete course of the appropriate antimalarial medication or medications must be given. Causes Plasmodium falciparum, as the commonest and responsible for most of the deaths and morbidity associated with malaria. Also, Plasmodium malariae and Plasmodium ovale. For uncomplicated malaria, the symptoms are fever, chills, rigors, sweating, headaches, generalized body and joint pains, nausea, vomiting, loss of appetite, abdominal pain, especially in children, irritability, and refusal to feed in infants. The signs that are usually elicited are fever, mild pallor, mild jaundice, splenomegaly. Investigations are microscopy, take and thin blood films for malaria parasites, rapid diagnostic test, FBC, other tests as indicated. So the main treatment objectives are to avoid progression to severe malaria, to limit the duration of the illness, and to minimize the development of drug-resistant parasites. For non-pharmacological treatment, in children, tepid sponging to reduce body temperature. Pharmacological treatment includes drug combinations, and artesunate amodiaquine co-blasted formulation, um, artesunate um, amodiaquine fixed dose combination, and artemether dosing regimen, and dihydroartemisinin piperacin dosing regimen.